Okay, so next is brachial embolectomy. 62-year-old male present with 3-hour history of sudden and onset right arm coldness, paresthesia, pallor, and pain. He can just move about his fingers, and forearm muscles were supple and non-tender. He is known to have atrial fibrillation, was on warfarin, but his INR today was 1.3. There was no other significant history of note on examination. The right hand was pale and the right brachial pulse absent. All pulses were palpable in the other limbs. What is the diagnosis and the possible differential diagnosis? The diagnosis is acute embolus of the right arm and the sudden compromised blood flow to the limb threatening the viability. Treatment should be prompt to avoid irreversible damage. After 3 to 8 muscle nerves and may suffer irreversible damage, and more prolonged delay may cause vacuum ischemic contracture. Differential diagnosis include the aortic dissection, cervical rib, given thoracic outlet syndrome. How would you investigate this patient? So this patient needs baseline investigation with the full blood count, UNEs, clotting profile, and creatine kinase to load muscle breakdown, and troponin CKM to load cardiac events. ECG to confirm the arrhythmias, and chest X-ray to look the size of the heart and lung condition, and echocardiogram and 24-hour Holter monitor. That will take place after the surgical management. And brachial arterial imaging either with a CT angiogram of upper limb to confirm the diagnosis or duplex ultrasound scan, and that will give us the details about the arterial tree and level of obstruction, and we can also give an idea where we should give incision. Given this patient history, what does the procedure require? Right brachial embolectomy. Describe your procedures. It can be done under local or general anesthesia. Patient arm will be in a spine position, lazy agency over the cubital fossa. That will, because in the cubital fossa, the brachial artery is hidden by the bicipital brachii aponeurosis, and medially of the artery is the median nerve, and laterally is the tendon. So we need to divide the aponeurosis to give access of the brachial artery, and then brachial artery and transverse arteriotomy, and dissect out the radial and ulnar artery. So and get control of all these arteries, do proximal embolectomy, then distal embolectomy, and before applying clamp we should do the heparin, and we should flush these arteries with the heparinized saline. And once good backflow bleeding is achieved, no further arteriotomy is closed with the 6 opening stitches. Are there any other treatment options? Thrombolysis is also option, but there is a risk of distal embolization and 1% hemorrhagic shock. And embolectomy is probably a safer option for this patient. For lower limb acute emboli, as per style and Topaz trial, thrombolysis and embolectomy has equal results. Thank you.